All right, just want to remind everybody again, if you just put away your cell phones, turn them off, just put away anything that's going to distract you so that we can get through this and you can hear what we're saying. Okay, so I just want to review the first part of what we've been over. Say that, but it's not going anywhere.
Not going. Let me get it.
Okay, so I just want to review that you have to document all your communication in the patient chart. So if you're talking to somebody in the hallway, whatever, if you've made phone calls, if you're talking to a caregiver, whatever it is, you need to document that communication. After you do an admission or a therapy evaluation, you need to call the doctor's office and you need to document. It's not going anywhere. Hold on just a second. We're having technical difficulties.
I may not be muted. You're going to breathe.
You gotta be
You digit.
Okay. How did you do that? Okay. All right.
Is that more than one? These errors right here?
Mm-hmm.
Let's go back and forth.
Yeah, I did, but it wasn't going to do anything.
Is there a good, you know?
You gotta go back. You just gotta push it from it.
Okay. Sorry about that, guys. Okay. So you need to document that you called the doctor. You need to document who you talked to, and you need to put in the communication, reviewed plan of care, received verbal approval of plan of care. Okay? You also need to document your visit in the patient folder, so you should be asking for the patient folder every time you're out there. Communication with the aide, the home health aide is important. Your care plans must be specific. Please document all you do, see, hear in a patient's home and what the patient does and says. And that sounds like a lot, but you do an assessment, but give yourself credit for everything that you do. You have to have an order for everything you do. Only do what you have an order for. You must have a care plan with goals and interventions for each discipline that are specific to the patient. Always use 2 identifiers to identify the patient, and don't use abbreviations if you're not sure that they're acceptable. Okay? We talked about last week that with the new conditions of participation, that the patient has the right to pick a representative. And you must document who that representative is, or that they said, I don't have anyone. I don't want to choose anyone. Your communication must be with the patient and their representative if they've chosen one. And then in advance, a consent must be signed and the patient given their rights before any care or any instruction can be given by the clinician. So in other words, if therapy gets out there first, therapy has to give the patient rights to the patient and get a consent signed. We talked about that a little last week, and we'll give you some more fine details of what you do with the consent that you got signed, and so we'll go a little bit more, but that definitely has to be done. Okay?
Hey, Melanie.
Yeah?
If a patient, like say we already have a patient established with us prior to the new participation conditions or whatever, do we have to ask them if they want a representative in January, if we already have them open or no? Yeah,
if we already, it's January 13th is when, don't ask me why that date, random date in the middle of January. But January 13th is when the new conditions start. So we are going to actually have our new handbook ready next week. I say that. And so all existing patients, so all new patients, the new handbook will be in the folder. Then all existing patients, yes, we will have to take out those 1 time a month Foley catheters, the ones that we've had open and we're reserting. They're going to have to get a new patient handbook, and yes, we will have to document who their representative is.
Okay, I was just checking.
Yes. And again, those are the fine details that we'll start on next week. Okay. Please be familiar It says my internet connection is unstable. I don't know if that's telling me I'm unstable or the internet connection. Okay, so please be familiar with the rights in the patient handbook. And for those of you who don't do admissions, that doesn't mean that you should not know what the rights are. You should get a patient handbook and you should look at it. You should know what those patient rights are. You should know what our discharge policy is. You should know what the complaint policy is. And we're trying to go over these things, but you should be familiar with that. So if a problem comes up, just because you're not the admitting clinician or the one that goes out and does the discharge OASIS, you should know about Heaven Sent. Home health is home health, but each agency that you work for has a little bit different policies. But you need to make sure you know us. And the patient must receive a written copy of their rights, and they must be gone over verbally by the second visit. So there we go with that. Whoever gets out there first has to give them the written copy, and then by that second visit, so if the therapist visits in the morning, they can hand them a copy of the written rights, but by the time the nurse gets out there to do the real admission, then you have to go over them verbally. And that does not mean read every single little word, the ands and the these, but it means know your rights, know what you need to go over with that patient. And we'll, believe it or not, we'll go over that with you too. Aren't you excited? Okay, comprehensive assessment. That comprehensive assessment that's exactly what it is. It's the assessment of the patient from each discipline should be patient-centered care. Okay, so when we go out to admit a patient, I think sometimes what we do is we just are generic. Patient can walk 300 feet. Patient will learn their medicines. Patient will understand the disease process. Very, very generic, okay? But what Medicare wants us to do is to look at that patient, and if that patient has been non-compliant in the past, figure out why. You know, what's going on with that patient? Can they not afford their medicine? Is that why they don't take it? Can they not afford to eat healthy? Which most of us, it's very expensive to eat healthy, and most of our patients are on a fixed income. You know, so are we really looking at the patient, or are we just throwing a goal and an intervention out there because that's what we're supposed to do? That's what care planning is about. I don't know about y'all, but in school, care planning was just like a far out thing of like, what the heck are they asking us to do this for? And it wasn't until I got to home health that I really understood what care planning was about. We're supposed to look at these items: the patient's strengths, their awareness of the disease process, the knowledge of their medicines, their motivation and ability to perform self-care or therapeutic exercises. So if we're going out and we're saying that the patient is going to know their home exercise program, and we know that patient doesn't even lift the finger to push the remote, then that's not realistic. Understanding of their diet. So they can understand what they're supposed to eat, but when their family gets Burger King, what are they going to do? They're going to get Mom Burger King too, because the daughter's running home from work, throwing something on the table, and then going out to soccer practice. That's the reality of life, okay? Vocational interests and hobbies. Now that sounds really crazy, but again, you know, if that patient used to crochet or that patient used to do whatever, how come they can't do that anymore? Is that something that they would like to get back to be able to do? Okay? Interpersonal relationships and supports. Again, we can say that caregivers are worthless, caregivers don't want to help the patient, but again, let's look at the reality of it. They're trying to do a job, they're trying to take care of their family, and all of a sudden now they have Mom and Dad to take care of. That is very, very difficult. And if you've never taken a child, taking care of a child is one thing, because you can take them to the babysitter. But when you have an adult that you can't take to the babysitter and they can't be left alone and you're trying to support your family, believe me, it is very, very difficult. And then again, their financial stability. All of that is your patient. And that's what home health is about. And that sounds pretty overwhelming, but that is exactly what the system is saying. We really need to look at the patient and not just throw something on a piece of paper that will suffice for a care plan. Okay? So what they're asking us to do is empower the patient to take an active role in their care. Engage the patient to take an active role rather than informing the patient what will be done for them. So again, instead of saying the goal is 300 feet, ask the patient what is the realistic goal for them. Well, honey, I would just really like to go in there and be able to sit with my family at the dinner table. Great, then that's your goal, and then you get them there, okay? Goals should be patient-specific, objective. They should be adapted to each patient based on the medical diagnosis, physician orders, your assessment, what the patient is saying, and specific treatments that you're doing. It should be individualized, not canned. So that means that when the auditor comes out, they're going to look at that plan of care, they're going to look at your goals, they're going to look at your interventions, and if you have 15 beautiful interventions and goals, but it has nothing to do with your patient, we'll get cited on that. Because think about it, it just doesn't make sense to do it that way. Okay, outcomes. And outcomes are in Brightree, okay?
You need to put them in. You can get out of the evals without outcomes, but you need to be putting those in. A lot of them are not there, so you can customize them, but they're easy to customize.
Okay? And that's your measurable outcome is the change in health status, functional status, or knowledge, for example, which occurs over time in response to a healthcare intervention. Outcomes may include end result functional and physical health improvement and stabilization. So when we look at our OASIS and under Medicare Compare, where it compares us with other health agencies, that's exactly what they look at. They look at the outcomes. So they look at how many of our patients went from walking with a walker to improving and walking with a cane, okay? If there's no improvement, then that's just they remain the same. What we don't want is a decline, okay? And we do open some patients that we know immediately they should be on hospice, whether they're choosing that, whether the doctor's choosing it, the family, but we know that that's going to happen. There's going to be a decline. We don't want that to happen, but we know that's reality, okay? The actual change in patient health status can vary from patient to patient, ranging from decline, no change, to improvement in patient condition or functioning. So again, when you are doing that OASIS and you are putting down your 0, 1, 2, 3, 4, please, please, please make sure that you're watching the patient. Make sure that you're getting the patient up and moving them. Make sure you're reading the question and you're doing it appropriately. After we go through the conditions, we'll start on OASIS again, okay? There should be no zeros, very few ones, okay? And then, we've said this before, if you do the OASIS and there's a deficit with transfers, then that should be where you're looking to improve the patient. That's where you should be looking. That should be something that improves when we discharge them. So think about that. Go back. Don't just throw the numbers into the OASIS and then separate that out from when you're doing your goals and interventions. You should look at your OASIS and say, wait, here's where the deficits were. That's what we should be working on. And I don't think we do that. I think we do the OASIS, we put it in a box and put it away and never look at it again until we have to do a recert or a ROC or a discharge. And then we look at our goals and again, we throw generic things out there. And if I'm wrong, but I don't think so. Okay. Care expectations. So this is what they're expecting. Each patient will receive an individualized written plan of care. Each plan of care will specify the care and services necessary to meet the patient's needs, including patient and caregiver education and training the agency will be provide specific to patient care. The individualized plan of care will be revised or added at intervals as necessary to continue to meet the patient needs, meaning that if they've met one of their goals, then that should be resolved and we move on to the next thing, okay? Or If we see that they're not meeting it, then that's when, if a LPN is seeing the patient or a PTA is seeing the patient, you should be calling your supervising nurse or PT or OT if you're a CODA, and you should be saying they're not progressing as they should, okay? And maybe you need to revise something. Maybe they're not going to meet it in 2 weeks or 3 weeks. So you need to look at those things. Again, it's not, we put the patient in for 2 times a week for 4 weeks. That's what we're doing. We're seeing them. We're discharging them. That's it. That's not what it's about. It's about making sure that the patient is meeting their goals if they're not, figuring out why, and revising it if we have to. Okay? It's like saying in your personal life, I'm going to save $100 by the end of the year. Okay? And when you get to the middle of the year and you've only got $1 saved, you're probably going to regroup and look at your goal and say, that's not going to be attainable. I need to figure out how to attain that or either have a different goal. It's the same thing with the patient. The plan of care includes specific measurable outcomes as a result of the plan of care prepared. So if you don't know where to document outcomes, then please see one of us so that we can go over that with you. All right, plan of care orders. Okay, so what happens is when you admit a patient or a patient is admitted, you put in your orders, and they are carried over to the plan of care, which used to be in the old Medicare world called a 485, because that's just the number that the form is. Okay, it's a Medicare form, but everybody uses that. It's not a requirement that we use that form, but most systems are set up that we use it that way. So all your orders carry over, all your care plan carries over, everything carries over to this form, and that's what the doctor signs to say, I approve of this plan of care, and I approve that what they're doing out there, that's what they should be doing. Please remember again, do not put 5,000 things. The plan of care should not be 10 pages. I think it's up there. It should not be 10 pages. It should be specific. Okay? The frequencies of the visits need to be consistent with patient condition and diagnosis. Meaning, if you've got an acute exacerbation of something, you should not be seeing the patient just weekly. Okay? You should be seeing the patient more. They've just been in the hospital. They've had a problem. They've just fallen 10 times. Okay? So we're not going to... If we're teaching them something, if we're doing an IV and we're teaching the family, or we're teaching them wound care, or teaching them an injection, you're not going to just see them and then not see them again for weekly. Because I want y'all to think about weekly. We can admit the patient on Monday. We can say we're going to see the patient weekly. And we move patients, and we'll talk about that at another time. We move patients, and so that patient weekly may not be seen until the next Friday. That's kind of scary. Okay? Your PRN orders need to be specific to the patient condition. You can't just say 10 PRN, it changes patient condition. You cannot say that. It has to be specific. So if it's a wound back, then it would be trouble with the wound back. If it's a Foley, trouble with the Foley. If it is, I don't know, I can't even think, right? CHF, change in patient's weight. You can't just say change in patient's condition. It doesn't work, okay? Your orders must be followed, including your vital sign parameters. Okay, now I want y'all to think about this. There are standard orders that go in on every patient. If they're diabetic, there's standard diabetic orders. If they're a CHF patient, there's standard orders for CHF. And those are just your basic things. If it is, what's the other standard order? CHF, diabetes, the pulse ox, okay? We can't do a pulse ox without an order. That's why we have that standard order. But the vital sign parameters, if I could get a show of hands, which I can't see your hands, but I bet you that you probably don't even know what the parameters are for your patient. Okay, because you haven't been looking at them. You have to look at those. So if you take a blood pressure and your blood pressure is 170 over 80 and the patient says, oh yeah, that's what it usually is, don't worry about it. But your order says that you're supposed to call the doctor at 150 over 80, then you haven't followed your orders because you haven't called the doctor when that blood pressure was above 150. Again, your goals must be attainable and specific to the patient. Less is more, okay? And that, again, that means not 10 pages of beautiful, beautiful stuff that you can click that button on Brightree and it just, wow, it's gorgeous. It means nothing. All right, medication review. Okay, now I'm going to talk about the last sentence here because as an epiphany came off to me this morning while I was getting dressed. Okay, so I hear somebody's baby, so somebody mute. Sweet sounds, but somebody mute. Okay, so in therapy cases only, the therapist submits solicited medications as collected during the comprehensive assessment to a nurse for review. That means a nurse always reviews your stuff. Dave or myself or somebody in this office always looks at everything that comes in this office, okay, on admissions. And the statement that I put here is that the med list will need to be turned in within the office within 24 hours. So that means, like anything else, your stuff is due the next day, guys. And I know that puts a lot of pressure on you, but that is just good practice. We have people going out to see patients who don't have a med list, who don't have orders, who don't know what the nurse or therapist did on the first visit because their note is not closed. That's just poor practice. It's going out blindly. Yes, do we have the stuff from the hospital? Sure we do. But what if that nurse or therapist called the doctor about an issue and it's not there and we don't know about it, and we go out the next day and call the doctor about the same issue, or the patient looks at us and says, well, they took care of that yesterday. Okay, it just doesn't make sense. You have to get your stuff in. So what will happen is you get your med list in, and then a nurse will review that. Okay, just to make sure, even though our system is supposed to pull up if there's if they mix or don't mix together, and I'm sure there's a word for that, I can't think of it right now. Interactions, that's a good word. Thanks, Gretchen. Even though our system does that, we will still have, if a therapist opens the case, we will still have a nurse review those medicines. Okay? All right. Before we get into any questions, let me give you the word. And the word is eponym. And it is EPONYM. And just remember, you need to email, text me, you need to call me, whatever you need to do to let me know that you have the word. Again, it's eponym, EPONYM. Okay? So, any questions about anything that I've said this morning?
If they don't get their paperwork in, can we make it that they have to do the follow-up visit too, regardless of schedule?
Yeah, we can talk about that. No questions? You don't care?
Oh.
It was clear?
Are they muted? Do you need to unmute them?
Oh, I don't know. Hold on.
Up there.
No questions.
All right. Who has a question?
No questions.
Okay. All right. Then, again, we're just keep on going. Next Thursday, we go to another one. I appreciate y'all listening, and have a great day. I just keep pushing buttons. There's Shirley. She looks lovely.
Shirley, can you talk to Shirley? Is she still on?
Shirley?
Did not respond.
Thank you, Melanie.
Okay, thank you.